get started, so if you want to bring yourselves on up to the chairs, we'll get this going.
Hey, Happy New Year. Happy New Year.
Good crowd. Are you guys going to turn the music up higher?
Say what?
Are you going to turn the music up higher?
Yeah, no, I thought that was the plan, is it not?
Oh, we're live.
We're live, yay!
Just got the notification.
Hello everybody and welcome back. Happy New Year. Welcome back to 1 Million Cups. For those of you who are new, I think I see some new faces out there. 1 Million Cups is a networking event where we come, we bring in one of our fellow entrepreneurs from the community. They talk about their business, their successes, their failures. Yeah, sponsors. We should thank our sponsors. So we've got the Dream Bank for the space. Thank you, Dream Bank. Thank you, Field 59, for the presentation, the live streaming. There's still no coffee sponsor. Those
Starting Block.
Starting Block. Hi, Chandra.
Starting Block for hooking us up with everything.
Right. That we are looking, as far as announcements, we are looking for presenters for February. Looks like most of January is ready. We're looking for somebody there, but mostly February. So if you know anybody or you are interested in presenting, definitely reach out. Today we have Nicole with Advocate MD, but before we go into the presentation, we usually go around the room and have everybody do a little introduction, talk a little bit about themselves, and then we'll kick into the presentation. I am Trezzy. I'm a CTO services consultant, and I am also the MC here for 1 Million Cups.
And he did great. Let's give him 5.
Hey, thank you.
You nailed it. My name is Diana. I'm the lead organizer here at 1 Million Cups, and I'm also on a job search that seems to be primarily focused around nonprofits right now.
My name is Joey. I'm a technology investment manager at the Wisconsin Economic Development Corporation. So we're the lead economic development organization in the state of Wisconsin, and I work with entrepreneurs across all spectrums. So.
My name is Josh Helling. I'm an entrepreneur. My background is in software product development. I work with startups and growing companies on technology and product strategy.
All right. Hello, I'm Steve Quad, co-founder of 32 Auctions, a silent auction website for hosting and managing fun, easy, successful silent auctions.
I'm Kurt Peterson, the other co-founder of 32 Auctions.
I'm James Cademan. I have Calls on Calls, shared receptionist service. And if you guys could do me a huge favor.
Next week?
Yes, come next week because I'm presenting about an awesome new flower ordering website. And then January 17th next week is a business expo over at the Coliseum Bar upstairs as well. It's free beer. So.
I'm Nicole Hemkes. I'm presenting today.
I'm Dean Schroeder from Orange Tree Imports. You may have read about us in the news yesterday. We're okay, we're fine.
Hi, I'm Chandra Miller-Feenan. I'm the Executive Director of Starting Block Madison. We're the entrepreneurial hub that's on floors 2, 3, and 4 of this building. So welcome, we're happy to co-host a Million Cups down here with the Dream Bank. And if you haven't already done it and you're not on our newsletter, we have a community newsletter of all community entrepreneurial focused events that goes out twice a month. Not just the ones that are done here at Starting Block or at the Spark building, but anywhere we can find them across the state of Madison. So it's sort of a one-stop stop for finding events like 1 Million Cups.
I'm Peter Daly, relevant to this presentation. I'm part of the Center for Patient Partnerships at the UW Law School.
Hi, I'm Keith Fuller, and I'm the founder of All About EX. That's a service that helps startups when they get serious about their people.
Dan LaCloche, I'm a content marketing consultant, and I'm also a lifestyle brand.
Craig Budenstein. I'm here interested in entrepreneurship and currently seeking opportunities for future employment.
John Held, Springfield Welding at Mascase Products.
Michelle Jolly, health coach, working with busy entrepreneurs who don't feel like they have time to for themselves or eat healthy.
I'm Julie Jensen. I'm the Director of Development for Our Lady of Hope Clinic, and we are another direct primary care clinic here in Madison. We're actually a hybrid clinic, so we serve member patients, and if you don't know what that is, I'm sure Nicole will get into that. We also serve the uninsured. We provide free primary care to the uninsured in Madison.
Hi, Sarah Lasker. I own Healthy and Huga, which is a life and wellness branding coaching. Yeah, what do I do? Yeah. A lot of my focus is on type 1 diabetes and pre-diabetes. So if you are going to be around July 25th, 26th, come on down to the Well Expo at Malone Terrace. I'll be presenting on the 26th for pre-diabetes.
I am Peter Caddy. I'm with Bank of America Merrill Lynch. I'm a wealth management advisor with them, and happy to be with this group of fun, energetic people.
Hi, I'm Trent Fita. I'm a student at the university studying computer science and computer engineering, and I do websites and data services for the athletics department on campus.
Hi, I'm Tammy Taylor with CrossGen Solutions. We're a consulting company. So fundamentally, if you have any sort of business issue, give us a call. We'll probably be able to come in and help you or point you in the direction of somebody who can. And for those who successful startups, if you're ready to really take it to that next level, we can come in and make sure you've got a good solid business foundation upon which to launch your next growth initiative.
I'm Jay Barton from Barton Product Design. We're a local product design firm engaged in product design and product development.
Lisa Taylor, Director with the Veterans Business Outreach Center. We are funded by the SBA and we provide resources to business owners who are veterans, active military, and their spouses.
Hi, I'm Dan Anderson. I'm with the accounting firm of Baker Tilly.
JD Kopp with the wealth firm Bronfman and Rothschild, focused on like impact investing, socially responsible investing.
I'm Adam Schrager. I'm a storyteller with the American Family Institute of Corporate and Social Impact.
Dan Bowen, healthcare software currently, and just getting plugged into the entrepreneur environment here, looking to launch something hopefully this year.
I'm Derek Kebler. I'm a VP of broadcast and video at Town News, part of Field 59. Field 59 is part of Town News.
It's been a hard work.
Yeah, I'm sorry. And I'm going to see how long I can hold this phone without actually balancing it on camera. Hi, everybody. Okay.
These are live stream and our
All right, great. Well, thank everybody for the introductions. We'll go ahead and jump into the presentation. So let's hear it for Nicole.
Hello, thank you so much for inviting me to come and talk about my new business, Advocate MD, which is a direct primary care practice. So I'd like to talk today about what direct primary care is, how I feel like it is one of the solutions to the healthcare crisis that we have right now. My background is I'm a family medicine physician, board certified. I've been out of training for about 10 years. In the last 10 years, I've worked in emergency departments, in hospitals as a hospitalist, in urgent care as an outpatient setting. So I've kind of worked in a variety of fields in both rural, very rural areas and urban areas, but have been in Madison for the last 3 years. So kind of want to start big picture, because I think that that's important to understand what's happening on a kind of more, macro level to see why our healthcare situation on a kind of an individual level is where it's at right now. So in the United States, we spend more on healthcare per person than any other developed country. Even similar GDP per capita countries, we are spending, you can see on the chart, and I didn't label each of these countries, but they're all kind of similar. I think Switzerland is this other one that's up here. Countries that we would consider to have a very high level of medical care and have a similar average income for their patients. But why are we so much higher above that line? And then the rate of healthcare spending, the rate of healthcare cost or pricing is increasing at a level that is higher than our general economy or any other sector of our economy. The healthcare is increasing at a higher rate. Why is that? So there are a few theories about this, but kind of the predominant theory that's happening right now is that there are two factors affecting this. In the United States, we have a much higher level of healthcare administration and more complex processes involving our healthcare than any other country, developed countries. And I think some of this could be traced back to different legislation that's been enacted in the last 30 years, starting with the way physicians are paid, up to patient privacy acts, and then the HITECH Act, about 10 years ago. So with each of these, it has increased the level of staffing and healthcare administration that needs to be required. But at the same time, the number of physicians has not increased significantly. This is pretty much just keeping up with the rate of population growth. But administration has increased by 3,500%. The other issue that they think is factoring into this is that everything costs more, everything is priced higher in the United States. It doesn't necessarily cost more, but the prices here that we pay for our drugs, our services, everything is higher than, again, in developed countries. And I just threw up some examples. Unfortunately, I can't talk too much, go into detail, but a knee replacement can vary in price anywhere from $30,000 to $40,000. Appendectomy, and then you see the price of imaging, whether you do it at an outpatient imaging center, it's $600. If you do it in a hospital, it's double that, more than double. So why is that? But why should we really care? Because we all have insurance, right? I mean, we're not paying the price of things, our insurance is paying it. And Madison is somewhat of a unique market. We are heavily insured here. I looked at statistics from 2016. 95% of people in Dane County have some form of insurance. That can be government insurance, Medicare, Medicare, but we are heavily insured here. So with the passage of the ACA, which the goal of that was to increase the number of insured people in our country, which it did do. There are different numbers as to how much this changed, but anywhere from 16 to 18% of Americans were uninsured. Now it's around 10%, but in the past year that number has actually gone up a little bit with the new administration, and now the individual mandate has been lifted. But so the cost of insurance, along with the number of uninsured people going down, the cost of our insurance has gone up. So I think probably most of you can relate to this. Our premiums have increased significantly in the last 8 to 10 years. And deductibles, so in 2008, prior to the ACA, the average deductible for an individual was less than $1,000. Now the average deductible for an individual is $2,500. For a family is $4,500. So we have seen significant increases in deductibles. And then our choices as far as coverage, if you are one of those people that purchase your insurance from the marketplace, there are about a third of counties in the United States which have one choice of your insurance if you purchase on the marketplace. So I'm kind of shifting gears a little bit, and we've talked about the financial part, the insurance part. We pay a lot for healthcare. Our prices are high. Now I want to talk about the experience of healthcare, and first I'll talk about from the physician perspective. So the new buzzword, if you go into hospitals, medical conferences, is physician burnout. Physicians are unhappy. They don't feel, satisfied with their job. We worked hard to get here. We spent a lot of money to get here, and the majority of us I would say they've done polls that have shown, would you choose this profession again? And it's close to like 50% or more would say no. And so we'll talk about the factors that are kind of controlling that. And I feel that a big factor is the feeling of not being able to take care of patients the way we would like to be able to. I've heard, the two determinants of job satisfaction, which I think this can be probably extrapolated to a larger, area of jobs, but the feeling of a sense of purpose in what you do, and then the feeling of autonomy in your job. So for physicians, obviously, I think for the most part, we feel a sense of purpose in what we do. We feel like we help people. But I think that slowly has changed because, and this will kind of go more towards the employee part of it, we have much less control over how we can care for patients in this current fee-for-service insurance industry. And then the sense of autonomy is basically gone for most of us if we are employed physicians, which now 60 to 80% of primary care physicians are employed. In the Madison market, I would say it's probably closer to 90%. As an employed physician, I am told what hours to be open, how many patients to see, how long to spend with my patients, who to refer them to. So this is where we're at. So it's not necessarily, I hate to share this dirty secret, it's not necessarily what is best for the patient. It is, this is what is best for the system, or how we can maximize billing and get the number of patients in the shortest period of time and code the correct codes. So we definitely feel that we don't spend enough time with patients. 10 to 15 minutes is just not enough time. We cannot cover everything that needs to be covered. And then unfortunately, along with the good that the EMR has created, it has created negatives. There is now a physical barrier between the patient and the physician, and there's a computer sitting in between you, and while you're in your office visit, most likely the physician is typing on that computer. It is basically where we're at right now, and it is not, bashing the doctor, because I have been there and this is the way things have to be in order to do the documentation that needs to be done. And then physicians are bringing on average 2 hours of work home with them a day. So a 10-hour day turns into a 12 or 13-hour day. And then you have the experience of having patients coming back in and saying to you, you ordered these labs and I got a bill for $200 or bill for $300, or you ordered this ultrasound and now I have a bill for $1,000. You didn't tell me it was going to cost as much. Well, I didn't tell you because I didn't know. There's no way the physician knows. There's no way the patient knows the bill that they're going to get. Nobody knows the cost of that. Maybe the insurance company knows, maybe the hospital knows, but those prices are not transparent in any way. So let's kind of turn it around and say, what is the patient's experience, which we kind of started on this. So I have a bad cold, I have a sore throat, I call my doctor, I want to get an appointment to be seen. On the phone they say, well, maybe it's going to be a couple days, it might be 3-4 days. Well, maybe I can't wait that long, so now I'm going to go into an urgent care clinic or an emergency department. Then if I do get an appointment, I get in to be seen, I'm going to wait in the waiting room for 45 minutes, and when I get brought back into the exam room, probably the doctor's going to spend about 15 minutes with me. And again, this is not Dr. bashing because I am part of the problem. You're going to be typing on the computer while you're talking to the patient, and your attention is divided between those two things. So the patient leaves feeling unsatisfied with the visit. Maybe they forgot to ask a couple of questions. Well, can I just pick up the phone and call the doctor in the office and say, wait a second, I meant to ask you about X, Y, and Z. No, you can't do that. There's no way you're going to call. I've worked in outpatient, and you're not going to call and talk directly to me because there's going to be a medical assistant or something, and I'm going to be seeing those other 25 patients I have to see during the day. So unfortunately, there's not enough time for that. And then again, I kind of touched on this, the unexpected bills of not knowing how much the labs are going to cost or how much the imaging is going to cost and the medications. And if I haven't met my deductible, I might be paying out of pocket for all of these things. So I think the patient is left feeling kind of lost, like they don't have an advocate, like who's going to stand up for me when these things happen to me? I can call and, maybe fight with the insurance company or fight with the healthcare system that I'm going to, but most likely nothing is going to be changed. So everyone's looking for answers to this problem. We have very expensive healthcare in this country. We have very expensive insurance. Yet, for the most part, I would say, doesn't necessarily mean our quality is any higher than in other countries. And it doesn't necessarily mean that their patient satisfaction is any better than in other places. So what is the solution to this? So everybody's looking for solutions, including the government, which, surprise, surprise, the government has not figured out the solution. But over the last 6 months, they have been having healthcare experts from around the country come and testify in front of the Health, Education, and Labor Pensions Committee to give them their insight into what they're doing in their little section of the country and if it's working, how it's working. So Dr. Lee Gross is a direct primary care doctor out of Florida. He runs Epiphany Health, which is one of the four founders of this movement. So he talked about his clinic and how direct primary care works, and the fact that in the last 9 years, he has not increased his membership charges. Unlike insurance, we talked about the cost of insurance, his overhead has not increased at all. So how is he able to do that? He also talked about the idea of, his quote that I really liked was, let's make the predictable affordable. So we have car insurance and we have home insurance, but our car insurance doesn't cover every time we need an oil change or every time we need air in our tires. So why does our health insurance cover every time we have a sore throat or a cold or need a blood pressure check? So the more we include in that, the more expensive it becomes. It didn't always used to be that way. We used to have indemnity policies. And then more recently, Senator Lamar Alexander has also talked about direct primary care on the Senate floor. So direct primary care is a movement that's happening across the country. It started up by a handful of very insightful physicians about 9 or 10 years ago in little pockets across the country, maybe a dozen doctors. And they decided that we're going to stop accepting insurance. We are going to bill the patient directly and have a contract between the patient and the physician. And by doing that, primary care doctors eliminate 30 to 50% of their overhead cost. And then, at the same time, because we can eliminate those costs, we can see fewer patients. We can spend longer with our patients. We can be available in between patients to take phone calls. We can be available after hours if you're sick or not feeling good, if something emergency or urgent happens, potentially even coming back into the office, but just being able to triage that over the phone. So over the last 9 years or so, this movement has grown to about over 900 practices across the country. In some pockets, and I think this map is not 100% accurate as far as the dots, places like Texas, Kansas, Oklahoma, Florida, this is exploding. There are many, many practices that has been slower to catch up in the Midwest, but we do have 7 or 8 of these in the Milwaukee area and then about a dozen in Chicago. So I think the insurance saturation in this market has been part of it, but again, this isn't about replacing insurance. So the kind of the main tenets of direct primary care, again, we try to remove barriers between the patient and the physician, barriers being the computer sitting in between us, having to document all of these things. Insurance and healthcare administrators, we're able to lower our costs significantly. We don't need billers and coders inside the office because we're not submitting anything. You're paying me directly. There's complete price transparency. Any of our prices will be listed on our website and marketing materials. I try to put all my prices out there so there's no surprises. Imagine complete continuity of care. Imagine you get sick on a weekend and you have a really bad cough. Could this be a pneumonia? Imagine calling your doctor and talking directly to your doctor, them saying to you, okay, well, either maybe it's something we can wait till the following day, maybe it's something you need to come in and be seen for. But avoiding going into an urgent care, an emergency department, which obviously is an additional cost, a physician that doesn't know you, that physician knows you, knows your medical history, knows, well, didn't you have pneumonia last year similar to this? So I mean, there are so many pluses to this. Being able to talk directly to your physician, again, that same example, if you call after hours to a normal primary care office, you're going to take the answering service. Your child is sick, you call the pediatrician. You're probably going to be triaged with a medical assistant or a nurse. So we talked about the availability, the accessibility. So everything is patient-centered. So if you have an elderly patient that has the flu and they're at home and they are too weak to get it, you can go and see them in the home. You have the time to do that because you don't have to see 25 patients a day. Maybe you have 6 or 8 patients on your schedule. So you can block a 2-hour block and go and travel to that person's home. And just this overall, feeling of advocacy and making the patient feel like they have somebody in their corner that's fighting for them. If it's whether it's negotiating, helping them negotiate a bill for something that they think, a lab, whether it's just having somebody, if they need a specialist, having you talk directly to the specialist. So this is a very busy slide, but I basically just copy and pasted the list that we have for patients, the list that we had for doctors' frustrations, patients' issues, and then direct primary care. So while direct primary care might not solve every problem, it definitely is a great start to trying to solve some of these big issues that we see. So this is my practice, Advocate MD. These are my prices, just because, like I said, we are completely transparent. There's nothing hidden here, and we want people to be educated consumers as much as we're able to be. So these are my prices per month. This is unlimited visits, phone calls, emails. If you need an in-office procedure, you need a mole removed, you wouldn't be charged for the procedure, you would be charged for the PAP, which might be $60 or $70. That is the monthly membership charges. And as you can see, it's not the concierge medicine of the 80s and 90s where people were paying $1,000 a month just to have the privilege to talk to a doctor in person or to have the privilege of somebody that would spend longer with them in their office visits. And then with concierge, they would still bill their insurance. And there are doctors still doing concierge very successfully across the country, but that is not what this is. This is meant to be affordable to middle-class working people. So I could do a whole lecture about the fallacy of pricing with insurance, but basically when we have insurance, and I have insurance, when we get a price, that price is artificially elevated and then negotiated down by your insurance, and then you have your part that you pay. So in our practice, we draw labs, we send people out for radiology, we don't have in-house x-ray, and we dispense medications from the office, wholesale pricing. And so the fallacy of pricing with insurance is that, I get a Z-Pack because I have a bronchitis. When I go to the Walgreens, they're gonna say, well, this Z-Pack was $80, your insurance paid $60, and your part is $20. And you think, that's a great deal, I just got $60 off of the Z-Pack. But the Z-Pack is $1.80. So it almost like blows your, first when you look at this, and I didn't realize this until less than a year ago, it blows your mind. The same thing with labs. I have gotten a lab drawn at one of the local labs here for a TSH, and I got a bill in the mail for $230 for one lab. That's a $4 lab. So this is how much prices are, and this is with insurance. So this is how much prices are elevated. And so if you come into my office and get a CDC, that we charge the wholesale price that we pay, we don't make any markup. The only way this model works is to the membership fee. That's the only thing we collect, we make a profit from. We don't make a profit from any of the other ancillary services. This is my website. I would like to open it up to questions and see, I'm sure there are questions about this model. Yes?
So as a patient, what additional insurance do I have to carry to cover emergency care costs if I get in a car accident and that ambulance ride or that helicopter ride that's $5,000 to $35,000 depending on which it is?
Sure. So we do recommend, so we will do as much as we can do in the office, and they say primary care doctors can handle 90% of medical issues, and we can, because we do after hours, avoid sometimes emergency room visits. But obviously, if you get in a car accident, you have like an acute appendicitis, you need to go to the hospital. We do recommend that you have some sort of high deductible insurance policy. There are many options. There are these things called health shares, which most people have never heard of. Liberty Share, Medishare, Sedera. What they are is a pooled risk that people pay into. It's not considered insurance, but it was given, there's a loophole in the ACA that this was included, that your individual mandate would be satisfied with this. But so these are much cheaper than insurance. People pay into it, and then if you have something catastrophic happen, depending on the level you're paying into it, whether it's $6,000, $8,000, then you pay up to that amount, and then everything above that, the health share pays for. There are things called short-term limited duration insurance policies, STDLs. So they used to be very restricted. One thing that the Trump administration has done is expand insurance options in terms of, so they used to only allow you to have these STLDs for 3 or 6 months at a time. Now you can have them up to 36 months. They're catastrophic policies, so you can have very high limits, your deductible can be set high, but you can now have these for a longer duration. So high deductibles, health shares, short-term limited duration policies. So we recommend that you pair with one of those, because but the sad part is, if you negotiate a cash price at a hospital, so in some areas of the country like Florida with Dr. Gross, they are negotiating bundled pricing at hospitals for like knee replacements, if you need hospitalization, and they're doing cash prices per day, because what we pay now, it's all a false. The $35,000, it's a false. I mean, they set that price at whatever they want to set it at, right? Like, why is one day in a hospital $4,000? Why is an emergency room visit $3,000? I mean, those are all numbers that are made up. So I still recommend that you have some insurance, but the sad reality is that if I walked into a hospital with no insurance, they would give me a better price. They would give me like 90% off my bill, right? But because I have insurance, they're like, everything gets jacked up, and then if you're, depending on your deductible, then you pay out of pocket whatever's left over. But yes, I do recommend that people have an insurance policy.
How does prenatal care work into your system of membership?
So prenatal care is a little bit complicated. So I can handle prenatal care in the office. I mean, I can deliver babies. I choose not to deliver babies just because of the liability cost, which in Wisconsin is actually not that bad. But so women automatically, if they become pregnant and can't afford insurance, they will, through Medicaid or Badger Care, be insured because they are pregnant. So it's usually not too much of a cost issue. So I would say if they have insurance, I would probably defer to their insurance for the prenatal care and cover everything else with them. Same way a woman would go to an OBGYN and go to a primary care doctor. So I wouldn't say that I replace an OBGYN and I wouldn't do deliveries. But if they needed me to do their prenatal care and their postnatal care, I could do that. And that would be included. Yes.
What's your staffing plan as a whole, as far as nurses, receptionists?
That's a great idea. That's a great question. So
as you grow.
Yeah, these practices, most of the time, that chart that I showed of the 900 practices, the majority of them start out as one physician that does everything. Some of them start with a nurse. I am by myself until the practice grows. Now we're in double digits. When we get into 3 digits or whatever, then I probably will bring somebody on. But the idea is that I want to keep the overhead low. So right now my biggest cost is my space that I'm renting, but I'm not taking a salary. I'm not paying anybody's salary. So I can keep costs very, very low. So I'm the only person, and then usually at some point where I start to get busy enough, I will add somebody. But I'm the one that draws the blood. I take the vitals. I take out the trash in the bathroom. It's a model that. It's funny though, when you have ownership in something, how you kind of don't mind it, because it's like something that you own, that you're building, that you maybe I'm working a little bit harder. Well, now I'm kind of working 2 jobs because I moonlight on the side on nights and weekends. But so it's just funny though, because when you're building it up, it's exciting, and you don't mind doing all those other little tasks. But yes, eventually, and my hope is to scale it in terms of, there are DPC practices in Kansas and Dallas that have multiple locations that employ, so I can bring on a physician in a year and employ them probably, and all of that. So I hope that it grows. Yes?
So, if it's safe to say that most primary care physicians don't enter the practice so that they become business owners. That's something, they want to be doctors, not business owners. Might your model lend itself to a franchising concept? I mean, if this is something that is a great idea, can save tons of money in the system, can give doctors opportunities, physicians opportunities, I mean, it sounds like a business that you can scale. And listening to your talk, I'm led to think, rightly or wrongly, that every physician that wants to do this is kind of on his or her own to create their own model and make it work, as opposed to, let's just see what's working across the country, let's put it in a paper bag and sell it to everybody else that wants to do it this way.
Yes, I think you are right in what you're thinking. So there is a network of direct primary care physicians across the country that we're kind of in this group, and we do help each other out. Like, okay, so how did you, what did you do for your equipment? What supplier did you go through? We do have a group purchasing organization, so we do get some discounts. For example, LabCorp, that's why I'm able to get those prices, those really cheap prices. But you're right, there are a couple companies, one of them is Diamond Physicians, which is based in Dallas. They are franchising this, so you can basically purchase from them. There's different ways, there's different companies doing it different ways, but some of them are doing a startup cost, and they're pre-packaging this and saying, okay, here's your DPC practice, because I don't want to be the one that has to go out and negotiate prices, or I don't want to be the one that has to figure out the marketing and the logo and all of these other things. But for the so there are franchises, and there are actually corporate-run DPC practices. Paladina in Milwaukee area, which now they're based, I think, out of Seattle, but so they run these corporate-based, still considered direct primary care, but they're very geared towards companies, so they don't do any direct-to-consumer marketing. It's all company-based, and some of them are on-site. But so yeah, there are people getting into this field that are looking on a broader scale. But yeah, the majority of them now are doing this all on their own. So they have individual names and marketing, and they're kind of like starting from square one. But you're right, I think a lot of doctors would like this type of model, but they don't want to do the work or the struggle of in the beginning and getting it going and all of that. Yeah.
Are you keeping patient records the old-fashioned way, which is a chart like a chiropractor does? Or?
So you can do paper charts. I will have an electronic medical record. It's called Atlas. It's actually built for direct primary care. It's a direct primary care doctor that helped build it. His name is Josh Ambar. He's out of Wichita, Kansas. So it's basic, but it does everything. It pulls my labs in. It does billing. It does, so it is sophisticated enough to do everything I needed to do. But in terms of the actual documentation and the notes, I mean, I don't have to worry about meaningful use. I don't have to worry about Medicare billing. I don't have to worry about, documenting to get a higher code of visit. I mean, none of that applies to me. So I can do the amount of notes that need to be done, and then, anything else, billing and all of that through that.
Okay, it is 9:30, so I want to make sure everybody can get on with their day when they need. Thank you very much. I appreciate it. Thanks. One thing I did want to request before you guys all leave, Kaufman has asked us to check in so that they know what kind of presents we're getting at each location. So if you ever plan on returning, which I hope you all do, if you could please download the app, and then next week we'll teach you guys how to check in so that they can start getting some numbers, and that way you can provide feedback so we can improve as an organization too. So if you can all download that, that would be great.